Welcome to Chapter 17, Aeromedical Factors. This chapter covers one of the most critical areas of pilot knowledge, understanding the medical and physiological standards required to operate an aircraft safely. Throughout this chapter, we'll examine the requirements for medical certification, explore the physiological hazards that pilots face in flight, and discuss the human performance limitations that every aviator must recognize and manage. Topics include spatial disorientation, vision in flight, and the effects of various environmental conditions on the human body. Whether you're preparing for a check ride or building your knowledge as an experienced pilot, a solid understanding of aeromedical factors is essential. Poor decisions related to health, fatigue, or physiological stress have been contributing factors in countless aviation accidents, many of which were entirely preventable. By the end of this chapter, you'll have the foundational knowledge to recognize these risks and take appropriate action to keep yourself and your passengers safe. This chapter covers the essential aeromedical factors that every pilot must understand to operate safely. We'll begin with medical certification, examining the different classes of medical certificates, the role of aviation medical examiners, conditions that may disqualify a pilot, and how special issuance authorizations work for those with certain medical histories. From there, we move into physiological hazards, the in-flight threats to your body and mind, including hypoxia, hyperventilation, ear and sinus problems, carbon monoxide poisoning, stress, fatigue, dehydration, and chemical exposure. We'll then explore spatial disorientation, covering the vestibular, visual, and postural illusions that can mislead even experienced pilots, along with the maneuvers used to demonstrate these effects and the strategies to cope with them. Finally, we'll take a close look at vision in flight, how the eye works, how lighting conditions affect your visual performance, and the scanning techniques that help you see and avoid other traffic. Together, these four areas form the foundation of aeromedical knowledge required for safe flight operations. Most pilots who want to exercise the privileges of their airman certificate must hold a valid medical certificate. There are a few exceptions worth noting. Pilots of gliders and free balloons are not required to hold one. Sport pilots have some flexibility as well, since they may use either a valid medical certificate or a current state driver's license to satisfy the requirement. However, regardless of what certificate type you hold, the regulations are clear on one important point. Under 14 CFR 61.53, no pilot may act as a crew member if they know of any medical condition that would make it unsafe to operate an aircraft. This applies to everyone, no exceptions. To obtain a medical certificate, you'll need to be examined by an Aviation Medical Examiner, commonly referred to as an AME. These are physicians who have received specialized training in aviation medicine and have been designated by the Civil Aerospace Medical Institute, or CAMI. One practical point to understand is that medical standards become more rigorous as the certificate class increases. If you hold a higher class medical certificate, you have automatically satisfied the requirements for all lower classes. The medical standards themselves are outlined in 14 CFR Part 67, while the certificate requirements are addressed in 14 CFR Part 61. Familiarizing yourself with both regulations will give you a solid foundation going forward. There are three classes of medical certificates, and understanding which one you need depends on the level of flying privileges you intend to exercise. The third-class medical is required for private and recreational pilot certificates. Its validity period depends on your age, 5 years if you're under 40, and 2 years if you're 40 or older. The second-class medical is required for those exercising commercial pilot privileges. It remains valid for commercial privileges for 1 year, but it also satisfies the requirements for private and recreational privileges for the standard 2 or 5 year periods based on age. The first-class medical is required for airline transport pilots, or ATP certificate holders. For pilots 40 and under, it's valid for 1 year. For those over 40, it's valid for 6 months when exercising ATP privileges. Like the second class, it steps down to cover commercial privileges for 1 year, and private or recreational privileges for 2 or 5 years as appropriate. One important principle to remember: a higher class medical certificate always satisfies the requirements for all lower classes. The required class only applies when you are actually exercising the privileges of the certificate that demands it. So if you hold a first-class medical but are flying as a private pilot that day, the lower-class validity periods apply. Having a physical limitation does not necessarily mean a student is barred from pursuing a pilot certificate. The FAA has established pathways to allow individuals with certain disabilities to obtain medical certification, though specific conditions and limitations will apply. Students with impaired vision, limb loss, or hearing impairment may qualify for a medical certificate valid for student pilot privileges only. Depending on the nature of the disability, special equipment may be required, for example, hand controls for a paraplegic pilot. Any limitations will be clearly noted on the certificate itself. A pilot with a hearing impairment, for instance, will see a restriction stating the certificate is not valid for flight requiring the use of radio. Once all knowledge, experience, and proficiency requirements are satisfied, the student may be eligible for a statement of demonstrated ability, commonly referred to as a SOTA. This waiver remains valid as long as the physical impairment does not worsen over time. For conditions that are specifically disqualifying under 14 CFR Part 67, a special issuance authorization may still be pursued through the FAA Federal Air Surgeon. This is a discretionary process that requires satisfactory completion of special testing, but nearly all disqualifying conditions can be considered. Providing stable, well-documented medical records to the FAA significantly improves the chances of approval. For specific guidance, students should contact their local flight standards district office. Under federal aviation regulations, specifically 14 CFR Part 67, certain medical conditions are considered disqualifying by history or clinical diagnosis. This means that if a pilot has ever been diagnosed with one of these conditions, it must be disclosed on the medical application and will trigger FAA review. The list includes cardiovascular conditions such as angina, coronary heart disease, myocardial infarction, cardiac valve replacement, permanent pacemaker use, and heart replacement. It also includes diabetes requiring oral hypoglycemic medication or insulin. On the mental health side, psychosis, bipolar disorder, and personality disorder marked by repeated overt acts are disqualifying, as is substance dependence or abuse, including alcohol. Neurological conditions such as epilepsy, unexplained disturbance of consciousness, and transient loss of nervous system control round out the list. Importantly, none of these conditions are automatically a permanent bar to certification. All of them may be considered for what is called a special issuance authorization, which allows the FAA to grant a medical certificate on a case-by-case basis with appropriate medical documentation and monitoring. It is also critical to understand that this list is not exhaustive. Many other conditions, including cancer, kidney stones, Parkinson's disease, multiple sclerosis, and certain blood disorders, may also require FAA review. When in doubt, applicants should consult an aviation medical examiner before submitting their application. Every pilot must understand how the body responds to the demands of flight, because physiological factors can impair your performance just as significantly as any mechanical failure. There are 4 key aeromedical hazards you need to recognize and take seriously. Hypoxia is the most critical threat. It occurs when the brain receives insufficient oxygen, typically at higher altitudes, and it's particularly dangerous because the symptoms, including impaired judgment and euphoria, can prevent you from even recognizing that you're affected. Hyperventilation is often confused with hypoxia. It results from breathing too rapidly, which causes an abnormal loss of carbon dioxide from the blood. Stress and anxiety are common triggers, and it can occur at any altitude. Pressure changes during climbs and descents can cause significant ear and sinus pain, and in some cases, a temporary reduction in hearing. This is especially problematic when flying with a cold or sinus congestion. Finally, carbon monoxide poisoning is a silent but serious threat. CO is colorless and odorless, and it can enter the cockpit from engine exhaust. It displaces oxygen in the bloodstream, and symptoms can mimic fatigue or other conditions, making it easy to overlook. Recognizing these hazards early is your first and most important line of defense. Hypoxia is one of the most dangerous physiological hazards a pilot can face, largely because it impairs the very mental faculties you need to recognize that something is wrong. The word itself means reduced or insufficient oxygen, and the brain is your most vulnerable organ. Even mild oxygen deprivation can degrade judgment, reaction time, and decision-making in ways you may not notice until it's too late. There are 4 distinct types, each defined by its underlying cause. Hypoxic hypoxia occurs when there simply isn't enough oxygen available to the body, typically because reduced atmospheric pressure at altitude means oxygen molecules cannot cross the respiratory membranes effectively. Hypemic hypoxia means the blood cannot carry adequate oxygen, with carbon monoxide poisoning being the most critical example. Hemoglobin binds to CO roughly 200 times more readily than it does to oxygen, making even small exposures extremely dangerous. Stagnant hypoxia occurs when oxygenated blood isn't reaching the tissues, which can result from G-forces, shock, or heart conditions. Finally, histotoxic hypoxia means the cells themselves cannot use the oxygen being delivered. Alcohol is the most common cause. And it's worth noting that just 1 ounce of alcohol raises your physiological altitude equivalent by 2,000 feet. Understanding these 4 categories helps you identify risks before they become emergencies. One of the most dangerous aspects of hypoxia is that it can be completely deceptive. As oxygen levels in the blood drop, a pilot may experience a euphoric, carefree feeling, actually believing everything is fine while their judgment and physical capabilities are seriously compromised. Other symptoms include cyanosis, which is a bluish tint to the fingernails and lips, along with headache, lightheadedness, slowed reaction time, visual impairment, drowsiness, and tingling or numbness in the extremities. The field of vision narrows, and interpreting instruments becomes increasingly difficult, all while the pilot may feel a false sense of security. Treatment is straightforward. Descend to a lower altitude and apply supplemental oxygen immediately. It's important to understand that physical fitness offers no protection. All pilots are equally susceptible. The time of useful consciousness table makes the urgency undeniable. At 45,000 feet, you have as little as 9 seconds to take corrective action. At 30,000 feet, only 1 to 2 minutes. Even at 25,000 feet, you may have just 3 to 5 minutes before incapacitation. These are not comfortable margins. The FAA offers physiological training, including altitude chamber flights through the Civil Aerospace Medical Institute in Oklahoma City. This hands-on experience allows pilots to personally recognize their own hypoxia symptoms before they encounter them in flight, and that awareness could save your life. Hyperventilation occurs when a pilot breathes too rapidly or too deeply, causing an abnormal loss of carbon dioxide from the blood. While it rarely causes complete incapacitation, the symptoms it produces can be seriously disorienting and, in severe cases, can lead to unconsciousness. Pilots are often unaware they are hyperventilating. Unexpected stress or anxiety can trigger an unconscious increase in breathing rate. Flying at higher altitudes, with or without supplemental oxygen, can also cause faster than normal breathing without the pilot realizing it. The symptoms of hyperventilation closely resemble those of hypoxia, which makes accurate diagnosis critical. Visual impairment, dizziness, tingling sensations, hot and cold flashes, and muscle spasms are all common indicators. Because of this overlap with hypoxia symptoms, always rule out oxygen deficiency first before assuming hyperventilation is the cause. Treatment is straightforward. The goal is to restore normal carbon dioxide levels in the blood. You can do this by consciously slowing your breathing rate, talking aloud, or breathing into a paper bag. Recovery is typically rapid once breathing normalizes. If you are on supplemental oxygen, verify that your equipment and flow rate are functioning correctly before proceeding with hyperventilation treatment. Recognizing this condition early and responding calmly is key to maintaining safe aircraft control. When we talk about ear and sinus problems in aviation, we're addressing one of the most common physiological complaints among pilots, and understanding the mechanics behind them is essential for safe flight operations. Let's start with the middle ear. During climb, the pressure inside your middle ear exceeds the outside pressure, causing the eardrum to bulge outward. You'll notice a sensation of fullness followed by a pop as pressure equalizes naturally. Descent is where things get more challenging. As external pressure increases, it exceeds the pressure in the middle ear, pushing the eardrum inward and compressing the eustachian tube walls. This makes equalization much more difficult and can become quite painful. The technique to relieve this is the Valsalva maneuver. Pinch your nostrils closed, seal your lips, and blow slowly and gently to force air up through the eustachian tubes. Sinus blocks follow a similar principle. If your nasal passages are congested due to a cold, infection, or allergies, the small openings connecting your sinuses can become plugged during descent, trapping air and causing severe pain, particularly in the frontal sinuses above your eyebrows or the maxillary sinuses in your cheeks. The key takeaway here is straightforward. Do not fly when you are sick. And before taking any decongestant medication, consult an aviation medical examiner, because those medications can impair your performance in the cockpit. Spatial disorientation is one of the most serious hazards a pilot can face, and understanding why it occurs starts with knowing how your body tries to orient itself in flight. Your brain relies on 3 integrated systems working together to determine your position, attitude, and movement through space. The first is the vestibular system, located in your inner ear. 3 semicircular canals, each aligned to sense motion along the roll, pitch, and yaw axes, contain fluid and fine hair cells that detect angular acceleration. When your head moves, the fluid shifts, bending those hairs and sending signals through the vestibular nerve to your brain. The second is the somatosensory system, what pilots traditionally call seat of the pants, flying. Nerves throughout your skin, muscles, and joints respond to pressure and gravitational forces. The critical limitation here is that this system cannot distinguish between gravity and the acceleration forces generated during maneuvers, which can lead to dangerously false impressions of your attitude. The third system is vision. In visual meteorological conditions, your eyes dominate your sense of orientation and generally override conflicting signals from the other 2 systems. However, in instrument meteorological conditions, when outside visual references disappear, your vestibular and somatosensory systems can generate powerful and convincing false sensations, and disorientation can develop rapidly. Understanding these systems is the foundation for recognizing and countering spatial disorientation in flight. Vestibular illusions are among the most dangerous hazards a pilot can face, because they cause you to feel something that directly contradicts what your instruments are telling you. Understanding each type is essential for maintaining control in IMC or low visibility conditions. The leans is the most common in-flight illusion. When a turn develops gradually below the 2 degree per second detection threshold, your vestibular system simply doesn't register it. When you then level the wings correctly, your body perceives that correction as banking in the opposite direction, and you instinctively lean toward the original turn. The Coriolis illusion is particularly powerful and disorienting. After a prolonged turn, the fluid in your semicircular canals equalizes and you feel straight and level. Any head movement in a different plane restarts fluid motion on a new axis, creating a sudden, overwhelming sensation of tumbling or turning. The key countermeasure is simple: minimize unnecessary head movement during flight. The graveyard spiral develops when a prolonged coordinated turn feels like level flight. Sensing a descent, the pilot pulls back instead of leveling the wings, which only tightens the spiral and accelerates altitude loss. Finally, the somatogravic illusion occurs during rapid acceleration. The otolith organs interpret that forward force as a nose-up pitch attitude, prompting the pilot to push forward, potentially into a dive. Trust your instruments above all else. The graveyard spiral is one of the most dangerous outcomes of spatial disorientation. When a pilot enters a prolonged coordinated turn, the semicircular canals stop detecting the rotation after roughly 20 seconds, and the brain interprets the banked turn as straight and level flight. When the pilot notices the altimeter unwinding, they instinctively pull back on the controls, but without correcting the bank, this only tightens the spiral, increasing the load factor and accelerating the descent until control is lost entirely. 2 additional illusions stem from the otolith organs, which sense linear acceleration. The inversion illusion occurs when an abrupt transition from a climb to a level flight causes a sensation of tumbling backwards. The pilot's natural response is to push forward, driving the nose down and potentially making the situation worse. The elevator illusion works similarly. A sudden updraft creates a false sense of climbing, prompting the pilot to push forward into a nose-low attitude, while a downdraft produces the opposite reaction. The common thread across all of these illusions is that your body's sensory system will lie to you convincingly and confidently. Prevention is your primary defense. Avoid flight in low visibility or night conditions unless you are fully instrument proficient. When disorientation occurs, you must trust your instruments completely and override every instinct telling you otherwise. Your instruments do not lie, your senses do. Visual illusions present some of the most dangerous challenges a pilot can face, particularly during night or instrument flight conditions. Understanding these illusions is critical to maintaining situational awareness and aircraft control. The false horizon illusion occurs when environmental cues such as sloping cloud formations, an obscured horizon, aurora borealis, or ground lighting patterns create the appearance of a level horizon that doesn't actually exist. When a pilot instinctively aligns the aircraft with this false reference, the result can be a seriously dangerous attitude, one that may not be immediately recognized until it's too late to correct safely. Autokinesis is equally deceptive. When you stare at a single stationary light source in a dark environment for an extended period, your visual system begins to perceive that light as moving. If you attempt to track or align with what you believe is a moving reference, you risk losing control of the aircraft. The simple countermeasure is to avoid fixating on any single light source. Scan regularly and use your instruments as your primary reference. The postural system adds another layer of complexity. Signals from your skin, joints, and muscles are normally interpreted relative to gravity. But in uncoordinated turns, climbing turns, and turbulence, acceleration forces can overpower those gravity cues entirely. This creates false sensations of position and movement. Skids, slips, and uncoordinated turns can all feel remarkably similar, and you may simply feel pushed sideways in your seat with no clear sense of what the aircraft is actually doing. Trust your instruments, not your body. These demonstration maneuvers are specifically designed to give pilots a first-hand experience of spatial disorientation in a controlled, safe environment. The goal is not simply academic. It is to make the physiological reality of disorientation personal and memorable, so that when it occurs in actual instrument conditions, you are mentally prepared to trust your instruments over your senses. The first maneuver involves closing your eyes while the instructor accelerates in straight and level flight. The resulting sensation of climbing is produced by inertial forces acting on the otolith organs, not by any actual change in pitch attitude. In the second maneuver, a 50-degree banked coordinated turn generates approximately 1.5 times the force of gravity. With eyes closed, this increased G loading feels exactly like a climb. Opening your eyes reveals the truth. You are in a turn, not climbing. The third maneuver keeps your eyes closed through most of the recovery from a diving turn, creating a convincing false sensation of descending while turning. The fourth demonstrates the leans. As the instructor rolls into a bank, a powerful illusion of rotation in the opposite direction is generated. Each of these maneuvers reinforces a single critical lesson. Your body will lie to you, and your instruments will not. These exercises must only be performed at safe altitudes and always with a qualified instructor or safety pilot present. Coping with spatial disorientation requires both awareness and deliberate action. There are 8 core principles every pilot should follow to reduce the risk of falling victim to dangerous illusions. First, make an effort to actually experience illusions in a controlled setting. Devices like a Barony chair, Vertigon, or virtual reality spatial disorientation demonstrator allow you to feel firsthand how your senses can deceive you before you encounter those sensations in the cockpit. Always obtain a thorough pre-flight weather briefing, and make sure you fully understand the conditions before flying in marginal weather. If you're going to fly in visibility less than 3 miles, or over open water at night, you need proper training and you must maintain your instrument proficiency. This is not optional. Avoid sudden head movements, especially during takeoffs, turns, and approaches to landing, as these can trigger the Coriolis illusion. Above all else, become fully proficient in flying by reference to your instruments, and then trust them completely. When your body is telling you one thing and your instruments are telling you another, believe the instruments. Your senses will lie to you. Through consistent training and honest self-awareness, you can learn to suppress those disorienting sensations before they lead to a fatal outcome. During landing, optical illusions represent one of the most serious hazards a pilot can face, because the visual cues your brain relies on can be completely misleading. Runway width plays a significant role. A narrower runway tricks you into thinking you're higher than you are, leading to a dangerously low approach. A wider runway does the opposite, causing you to level out too early and risk a hard landing or overshoot. Slope matters just as much. An upsloping runway or terrain makes you feel higher, so you fly lower. Downsloping terrain produces the reverse effect. In featureless environments, think overwater approaches, snow-covered terrain, or dark rural areas, there's nothing for your visual system to anchor to. This classic black hole approach scenario consistently causes pilots to fly dangerously low without realizing it. Environmental conditions add further complexity. Rain on the windscreen distorts the apparent horizon, pulling you low. Haze makes the runway seem farther away, again encouraging a low approach. Conversely, exceptionally clear air at high-altitude airports can make the runway look closer than it is, resulting in a high approach. Finally, be aware of lighting illusions. Fog can create a false pitch-up sensation. Road lights or moving trains can be mistaken for runway lighting. And bright runway lighting systems can make you perceive less remaining distance, causing a high approach. The consistent takeaway here is to always trust your instruments and use electronic glide slope guidance whenever it is available. Optical illusions are among the most frequently cited contributing factors in fatal aviation accidents, making it essential that every pilot develops strong habits to counteract their effects. The first strategy is to anticipate visual illusions before you ever arrive at an unfamiliar airport. Review airport diagrams and the chart supplement US ahead of time to understand runway slope, surrounding terrain, and lighting conditions. This preparation is especially critical when flying at night or in adverse weather. Second, make frequent reference to your altimeter on every approach, day or night. Your instruments tell you the truth when your eyes may not. Never allow visual cues alone to determine your altitude judgment. Third, when time and conditions permit, conduct an aerial visual inspection of an unfamiliar airport before committing to a landing. A low pass or orbit allows you to assess terrain and runway characteristics firsthand. Fourth, and perhaps most importantly, use every available glide path reference tool. VASI, PAPI, and electronic glide slope systems exist precisely to give you a reliable, accurate picture of your approach path. On non-precision approaches, utilize the visual descent point published on your approach charts. Maintaining proficiency in landing procedures is not optional. It is a core safety discipline. These 4 practices, applied consistently, significantly reduce your exposure to illusion-related landing errors. Motion sickness and carbon monoxide poisoning are 2 physiological factors that every pilot needs to understand, because both can seriously compromise your ability to fly safely. Motion sickness, or air sickness, occurs when the brain receives conflicting sensory signals about the body's position and movement. It's very common during early flight training, and the good news is that it typically resolves on its own within the first several lessons as your body adapts to the flight environment. Anxiety and stress can make it worse, so staying calm helps. If you experience symptoms, nausea, dizziness, sweating, or general discomfort, let your instructor know immediately. Keep fresh air flowing, focus your eyes outside the aircraft, and avoid unnecessary head movements. Avoid medications like Dramamine, as they cause drowsiness and are not safe for flying. Remember, experiencing air sickness says nothing about your potential as a pilot. Carbon monoxide poisoning is far more dangerous and potentially fatal. CO is colorless and odorless, and it binds to hemoglobin approximately 200 times more readily than oxygen, rapidly causing hypemic hypoxia. It most commonly enters the cockpit through heater and defrost vents when an exhaust system is leaking. Symptoms include headache, dizziness, blurred vision, and drowsiness. If you suspect CO exposure, immediately turn off the heater, open all vents and windows, and use supplemental oxygen if available. Install an inexpensive CO detector. It could save your life. Also worth noting, smoking a cigarette at sea level produces CO effects equivalent to flying at 8,000 feet. Stress and fatigue are two of the most significant physiological factors affecting pilot performance, and understanding the difference between their acute and chronic forms is essential for safe flight operations. Stress is the body's response to physical and psychological demands. In the short term, acute stress triggers the fight-or-flight response, releasing adrenaline, elevating heart rate, respiration, and blood pressure. A healthy individual can generally manage this. However, chronic stress is far more serious. Caused by ongoing personal, financial, or work-related problems, chronic stress exceeds a pilot's coping ability and causes a sharp decline in performance. Any pilot experiencing chronic stress should seek medical guidance and must not fly. Fatigue is one of the leading contributors to pilot error. It degrades attention, impairs coordination, reduces communication effectiveness, and leads to poor decision-making. Acute fatigue is a normal short-term condition that rest and adequate sleep can resolve. A specific form called skill fatigue causes pilots to perform tasks as isolated, disconnected actions rather than as an integrated flow, disrupting timing and situational awareness. Chronic fatigue, on the other hand, typically has psychological roots and cannot be relieved by rest alone. It requires physician evaluation and treatment. The bottom line is straightforward. If you are fatigued, stay on the ground. No level of training or experience can counteract the detrimental effects fatigue has on your performance in the flight deck. As a pilot, you will routinely work around potentially hazardous aircraft fluids, including hydraulic fluid, engine oil, and fuel. Understanding the risks associated with these chemicals and knowing how to respond in an emergency is an essential part of your physiological awareness training. For any chemical you encounter, always consult the Material Safety Data Sheet, or MSDS, for detailed safety information specific to that substance. However, there are minimum response guidelines you should commit to memory. For eye contact with any of these fluids, the immediate response is to flush thoroughly with clean water. Fuel exposure requires at least 15 minutes of flushing, followed by immediate medical attention. For skin contact, remove contaminated clothing and cleanse the area with soap and water. If fuel has damaged the skin, apply a clean dressing. For inhalation or ingestion, move the affected person to fresh air immediately. If breathing stops, administer CPR. A critical point to remember with fuel ingestion: do not induce vomiting, as this can cause the material to enter the lungs and cause serious additional injury. Seek immediate medical attention in that situation. Engine oil exposure through inhalation can cause dizziness, nausea, or even unconsciousness, all of which require immediate medical care. When in doubt with any chemical exposure, always seek professional medical attention rather than waiting to see if symptoms develop. Dehydration is one of the most underestimated threats to pilot performance. It doesn't take extreme conditions to become dehydrated. A warm flight deck, low humidity, or simply drinking coffee and tea throughout the day can accelerate fluid loss. The first sign is fatigue, which is particularly dangerous because it can easily be mistaken for general tiredness. If dehydration continues unchecked, symptoms progress to headaches, dizziness, nausea, and muscle cramps, all of which will directly compromise your ability to fly safely. The recommended intake is 2 to 4 quarts of water every 24 hours. Critically, do not wait until you feel thirsty. The thirst mechanism activates too late and shuts off before you've fully rehydrated. Heat stroke is the more severe outcome when the body completely loses its ability to regulate temperature, so ensure your flight deck is well ventilated and dress appropriately. Regarding alcohol, the regulations set a clear minimum standard: blood alcohol below 0.04% and at least 8 hours between your last drink and acting as pilot in command. However, even if you are technically within those limits, impairment can still be present. Judgment, coordination, memory, and reaction time are all affected even at very low levels. At altitude, the effects are amplified significantly. Alcohol also causes histotoxic hypoxia, meaning it prevents the brain from properly using the oxygen that is available. The only safe approach is conservative and deliberate compliance with both the letter and the spirit of the regulation. Federal regulations are clear on the subject of drugs and medications. Title 14, CFR 61.53 prohibits acting as pilot in command or required crew member while taking any medication that impairs your ability to meet medical certificate requirements. Additionally, 14 CFR 91.1 even prohibits the use of any drug that affects your faculties in any way contrary to safety. What many pilots underestimate is that medications behaving normally on the ground can produce serious adverse effects at altitude. Factors like fatigue, stress, dehydration, and poor nutrition all increase your susceptibility, and combining multiple medications can amplify those effects significantly. The MSAFE checklist addresses this directly. The M stands for medication, and it applies to both over-the-counter and prescription drugs. As a general rule, wait at least 48 hours after your first dose of any new medication before flying, and at least 5 maximal dosing intervals for anything with potentially adverse side effects. Knowing your drug categories matters. Prescription analgesics like codeine and oxycodone almost always preclude flying. Antihistamines, such as diphenhydramine, have a prolonged half-life and can cause significant cognitive impairment well beyond when you feel the effects. Depressants reduce mental processing and motor response. And regardless of state law, marijuana remains illicit under federal law, and the FAA prohibits its use by airmen without exception. The safest rule is straightforward. Do not fly while taking any medication unless it has been approved by the FAA. When in doubt, consult your Aviation Medical Examiner before you ever leave the ground. Decompression sickness, or DCS, is a serious physiological hazard that pilots and aircrew must understand, particularly when flying at altitude or after scuba diving. It occurs when a reduction in barometric pressure causes dissolved nitrogen in the body's fluids and tissues to form gas bubbles, similar to the bubbles that appear when you open a carbonated drink. There are 4 recognized types of DCS, each presenting differently. The bends involve deep, localized joint pain, most commonly in the elbows, shoulders, hips, and knees. Neurologic DCS can present with confusion, visual disturbances, vertigo, or even seizures and paralysis, making it especially dangerous in flight. The chokes involve chest pain and breathing difficulty, while skin bends cause itching, a crawling sensation, and skin discoloration. If DCS occurs in flight, your immediate priorities are to administer 100% oxygen, initiate an emergency descent, and land as soon as possible. Keep affected joints immobilized and seek evaluation from an aviation medical examiner or hyperbaric medicine specialist. Definitive treatment typically requires a hyperbaric chamber. Pilots who scuba dive must observe strict wait times before flying. After non-decompression stop dives, wait at least 12 hours before flying up to 8,000 feet and 24 hours before going higher. After decompression stop dives, a minimum of 24 hours must pass before any flight. These limits are not suggestions, they are critical safeguards for your survival. Decompression sickness, or DCS, is a serious concern for pilots and passengers who also participate in scuba diving. When you dive, the increased underwater pressure causes excess nitrogen to dissolve into your body's tissues and fluids. When you then fly and atmospheric pressure drops, that nitrogen can form bubbles in your bloodstream and tissues, a potentially life-threatening emergency. The waiting periods before flight depend on the type of diving performed. For non-decompression stop diving, you must wait at least 12 hours before flying to altitudes up to 8,000 feet MSL, and at least 24 hours before flying above 8,000 feet MSL. For decompression stop diving, the required wait is a minimum of 24 hours before flying to any altitude. One critical point to understand here, these altitude thresholds refer to actual flight altitudes above mean sea level, not the pressurized cabin altitude shown on your instruments. A pressurized aircraft flying at 35,000 feet may maintain a cabin altitude of 8,000 feet, but it is the true flight altitude that matters for this calculation. When in doubt, always extend your surface interval. The conservative approach is the safe approach, and no dive is worth the risk of a serious in-flight medical emergency. Understanding how the human eye works is fundamental to safe flight operations, particularly when it comes to recognizing the limitations that can affect your performance in the cockpit. The eye functions much like a camera. Light enters through the cornea, passes through the lens, and is projected onto the retina at the back of the eye. The retina then converts that light energy into electrical impulses, which travel through the optic nerve to the brain where the image is processed. The pupil acts as your eye's aperture, expanding or contracting to regulate how much light enters. At the center of the retina sits the fovea centralis, a small but critically important area packed almost entirely with cone cells. This is where your sharpest, most detailed vision originates. Now, understanding the difference between rods and cones is essential for pilots. Cones are concentrated in the fovea and give you color vision and fine detail, but only in adequate lighting. Rods are distributed throughout the periphery of the retina. They cannot detect color, but they are extraordinarily sensitive, up to 10,000 times more sensitive than cones in darkness, and they excel at detecting movement and low-light conditions. Here is the critical takeaway. Rods require up to 30 minutes to fully dark adapt. This has direct implications for night flying, which we will explore in the next section. There are 3 types of vision you need to understand as a pilot, and each one operates differently depending on the available light. Photopic vision occurs in bright daylight conditions. Your eyes rely on cone cells located in the fovea centralis, giving you sharp 20/20 or better acuity with full color perception. This is your most capable visual state, and direct central viewing works best here. Mesopic vision occurs at dawn, dusk, or under full moonlight, and this is considered the most dangerous period for visual tasks. Both cones and rods are active, but cone sensitivity is declining. You should begin using off-center viewing and deliberate scanning techniques during this transition period. Scotopic vision is your low-light, nighttime state. You lose all color perception, and your central visual field develops a blind spot due to the rod-free fovea. To compensate, you must look 5 to 10 degrees off-center from any object you want to see clearly. Acuity drops to 2200 or worse, so scanning becomes your primary technique. Finally, be aware of empty field myopia. When flying above clouds or in haze with no visual reference points, your eyes relax and focus at only 10 to 30 feet in front of you. You are essentially looking without seeing. Actively focus on distant light sources to keep your eyes properly focused at distance. When we talk about vision in flight, 2 specific blind spots demand your attention, and understanding both could be critical to your safety in the cockpit. First, the central blind spot. Every eye has an optic disc, where the optic nerve connects to the retina. This area contains absolutely no photoreceptors, no cones, no rods, meaning each eye is completely blind at that point. Under normal conditions, with both eyes open, this isn't a problem because an object can't occupy the blind spot of both eyes at the same time. However, if one eye's field is blocked, say by a windshield post or divider, a target could fall directly into the blind spot of your remaining functional eye and go completely undetected. Second, the night blind spot. Because the fovea is densely packed with cones, it actually becomes a liability in low-light conditions. Cones require bright light to function, so at night, looking directly at an object means you're using the least sensitive part of your eye. The solution is off-center viewing. Shift your gaze approximately 5 to 10 degrees away from the object to expose your rods, which are far more sensitive in darkness. Finally, dark adaptation. Cones adapt quickly, but your rods require a full 30 minutes to reach peak sensitivity. A single bright light destroys that adaptation entirely, and the clock resets. To get ahead of this before a night flight, wear neutral density sunglasses, specifically N15 rated, to begin the adaptation process before you even reach the aircraft. Effective night vision depends on 2 things: how you scan and how well you protect your eyes before and during the flight. When scanning at night, use a systematic pattern. Move from right to left or left to right, starting at the greatest distance and working inward. Scan in segments of about 30 degrees, pausing at each stop for no more than 2 to 3 seconds. Overlap each segment by 10 degrees to avoid missing anything between stops. Because your cone cells are less effective in low light, you'll also want to use off-center viewing. By looking 10 degrees above, below, or to the side of an object, you shift the image onto your peripheral rod cells, which are far more sensitive in darkness. Avoid staring directly at any object for more than 2 to 3 seconds. The rods will reach photochemical equilibrium, and the image will actually fade from your vision. Protecting your night vision starts before the flight. Wear neutral-density sunglasses in bright sunlight prior to night operations. Be aware that night vision degrades measurably above 4,000 feet, so consider supplemental oxygen even when regulations don't require it. Keep flight deck lighting as low as possible, use a dim white light for charts, and avoid looking toward brightly lit ground areas. At the airfield, reduce lighting intensity and position your aircraft away from bright light sources. These steps help you preserve the dark adaptation you've worked to build. There are several self-imposed stressors that can significantly degrade your night vision, and as a pilot, you have direct control over every one of them. Drugs, even some over-the-counter medications, can seriously impair your visual acuity both day and night. Always consult an aviation medical examiner or flight surgeon before taking any medication. Exhaustion causes slow reaction times and fixation rather than proper scanning, both of which are dangerous at night. Physical conditioning matters too. Regular exercise improves scanning efficiency, but excessive physical activity on the day of a night flight can leave you too fatigued to perform effectively. Alcohol impairs coordination and judgment and causes pilots to stare rather than scan. Its residual effects on visual scanning can persist long after you feel sober. Tobacco is particularly damaging. The carbon monoxide from smoking impairs peripheral vision and dark adaptation. Smokers can lose up to 20% of their night vision capability at sea level, which is physiologically equivalent to flying at 5,000 feet without supplemental oxygen. Finally, watch your nutrition. Skipping meals leads to low blood sugar, which degrades night performance. A deficiency in vitamin A also impairs night vision, so include foods like eggs, carrots, spinach, and liver in your diet. Managing these stressors is entirely within your control, and doing so directly protects your ability to see and fly safely at night. When operating at night, your ability to accurately judge distance and depth changes significantly, and understanding both the cues available to you and the illusions that can deceive you is critical to safe flight. During daylight, we rely heavily on binocular vision for depth perception, but at night, and at most aviation distances, that binocular advantage is essentially gone. Instead, you must rely on monocular cues. Motion parallax tells you that nearby objects appear to move backward while distant objects move with you. Linear perspective causes parallel features like runway lights or roads to converge with distance. Objects viewed at an angle appear foreshortened or elliptical rather than their true shape. Farther objects sit higher on the horizon, and aerial perspective means closer objects show sharper color and contrast. Night flying also introduces specific illusions you must be prepared to counter. Autokinesis causes a stationary light to appear to drift if you stare at it. Combat this by continuously scanning. A false horizon can form when city lights, stars, or shoreline lighting is mistaken for the actual horizon. Reversible perspective may make an approaching aircraft look like it's moving away. Changes in light luminance can be misread as closing or retreating distance. Fascination or fixation on a target is especially dangerous at night because ground closure rates are extremely difficult to judge. And flicker vertigo, caused by light cycling between 4 and 20 times per second, can produce nausea, vertigo, and in rare cases, unconsciousness. Recognize these illusions and actively counter them. Let's look at two important technologies that improve pilot awareness in low visibility environments: synthetic vision systems and enhanced flight vision systems. A synthetic vision system, or SVS, generates a computer-rendered image of the terrain and environment around the aircraft. It is not a live camera feed. Instead, it combines a digital elevation model database with a precise navigation solution to display terrain, obstacles, runways, and landmarks on a cockpit screen. Importantly, this image remains visible regardless of actual outside visibility, making it especially valuable during takeoff, approach, and landing phases. Currently, SVS is certified as a situational awareness aid on head-down displays only. Future developments may include ADS-B traffic integration and combined vision systems that merge SVS with enhanced flight vision. An enhanced flight vision system, or EFVS, is fundamentally different. It provides a real-time image of the outside environment using sensors such as forward-looking infrared, known as FELIR, or millimeter wave radar. This real-time capability is the key distinction from SVS. That distinction also carries regulatory significance. Since 2004, 14 CFR 91.175 has permitted operators using an approved EFVS on a head-up display to descend below the published decision height or minimum descent altitude on straight-in instrument approaches. This is referred to as operational credit. No such credit is extended for SVS alone. Understanding that difference is critical. Night landings introduce a unique set of perceptual challenges that every pilot must understand and respect. Your visual system behaves differently in low-light conditions, and the environment around you can create powerful illusions that lead to dangerous approach errors. When flying over featureless dark terrain, your natural tendency is to descend lower than intended. Similarly, rain, haze, and a dark runway environment all contribute to low approaches. On the other hand, bright lights, a wide runway, or steeply rising terrain can make you feel too low, causing you to fly a higher than normal approach. Be especially cautious of road or train lights, which can easily be mistaken for runway or approach lighting systems. Preparation is your best defense. Study your route during daylight before attempting it at night. Establish a firm minimum acceptable altitude before you ever leave the ground, and commit to turning back early if conditions prevent you from maintaining it. Be alert to areas near water where fog and low clouds can develop rapidly and obscure terrain. Consider supplemental oxygen earlier than regulations require, particularly for IFR operations, smokers, or anyone not in peak physical condition. Hypoxia impairs night vision even at moderate altitudes. Finally, maintain genuine currency and proficiency in night operations, and always choose the safer alternative. Hope is not a strategy when flying at night. This chapter has covered the essential aeromedical factors every pilot must understand to fly safely. Let's take a moment to reinforce the most critical points before moving on. Regarding medical certification, know which class certificate your operations require and when it expires. Remember that disqualifying conditions may be eligible for special issuance, but you must never exercise pilot privileges when you know a disqualifying condition exists. On hypoxia and hyperventilation, recognize the 4 types of hypoxia, use supplemental oxygen at altitude, and remember that your time of useful consciousness decreases rapidly above 10,000 feet. If hyperventilation occurs, consciously slow your breathing rate. When it comes to spatial disorientation, your instruments tell the truth. Your senses do not. Understand the vestibular, visual, and postural illusions that can mislead you, and commit to trusting your gauges in instrument meteorological conditions. For night flying, shift your gaze off-center by 5 to 10 degrees to activate your peripheral rod cells. Allow a full 30 minutes for dark adaptation. Scan systematically, and use your VASI or PIPI along with your altimeter to counter approach illusions. For deeper study, consult the Aeronautical Information Manual and the FAA website. And strongly consider attending the FAA Physiological Training Program at CAMI in Oklahoma City, which includes real altitude chamber and vertigo demonstrations that are genuinely eye-opening experiences.